Hi everybody, it's Professor Miller. This lecture is just going to cover a little bit about contract negotiations, certification, and essentially kind of a little bit about collaborative agreements in terms of clinical practice. I will put up other videos that will cover a little bit more details regarding the process of certification and licensure and all that separately. But I do want to go through this PowerPoint with you guys in general. So once you graduate, there's a multitude of different things that you kind of have to run through or set up essentially in terms of getting yourself ready for clinical practice. There is a Word document that I added that I listed basically a whole rundown of essentially the steps that you have to do in order to basically be ready for clinical practice. And I'm sure you probably already know some of this, but really the big thing, number one, is you have to become certified and you have to determine what certifying body you want to be placed under. And there's two major certifying bodies, one being ANCC and the other one is AANP. And I would say previously, back when I was in school, this was, gosh, a long time ago, that, ANCC was pretty much the go-to. And that's because it was pretty much the one that was around. Now, a lot of people are doing AAMP, so really both of them are good. You really just got to make that own personal decision of what certifying body fits you best. And I'll kind of give you a little bit of a rundown in another video with some differences between the two of them. I am personally ANCC certified. I know previous cohorts, when Dr. Mead was here, it seemed like they were kind of directing him in the sense of going through AANP. And I don't know the total underlying reason before that, but AANP has more of in terms of testing, it's directly clinical. There is not really much in terms of healthcare policy on there or leadership or insurance issues, things like that, where ANCC is mainly clinical, but they do have a little bit on there in regards to like health policy, legal issues, insurance. It's not a ton, but there is a little bit on there. So what I always recommend is to look at, honestly, you can get it on their websites and look at the exam blueprint. They both have exam blueprints and they tell you the topics that are essentially on there. And it'll give you like the percentage of each area or aggregates of questions essentially that are pulled from certain areas. So AAMP is definitely more clinical practice focused. So it's all based on like guidelines on clinical care, where ANCC has a tiny bit of other areas added to it as well. There is a little bit more questions on ANCC versus AAMP, and I'll get to this as we move through. So number one, that's the big thing you have to determine. What certifying body do you want to go through, ANC or AAMP? And they both have certification for both adult general primary care and family practice, obviously, too. So then once you get certified, then you're eligible for licensure through the state of Michigan. So once you get your certification or you pass your boards, that essentially gets transferred over to the state of Michigan, and then you're allowed to apply for a license. So once you're done, you're going to have a license for both your RN and a specialty license for NP. So you basically have to maintain both of them. In terms of maintaining your Michigan license, it's kind of confusing, but if you meet the requirements of what you need to maintain certification, because there's requirements that you have to meet to maintain certification through ANCC and AAMP. If you actively maintain certification and meet that criteria, it'll automatically fulfill your requirements at the state level for your licensure, if that makes sense. However, you have to watch too, because now like we have things about like human trafficking or sex trafficking that you have to complete for your RN license, and that may not be included in ANCC. But typically, all the continuing ed that you do and all requirements that you do for your certification through ANCC or AAMP will meet that requirement for the state licensure level. But once again, you have to be careful and make sure that you're getting that other criteria and like sex trafficking and things like that, or opioid agreement things that you have to do nowadays too, because that may not be a requirement for ANCC. But typically, everything you do to maintain certification will fulfill that. So once you pass, then you apply for licensure online, just as you do for your RN license. Same thing. You will also gather or apply for an MPI number, which I'll kind of explain in another video or later down the line. Your MPI number is going to be utilized very frequently for instance, like you use it for when you call in prescriptions or you e-script prescriptions. A lot of it was developed back when HIPAA was implemented in terms of Medicare and Medicaid, electronic billing and things like that. That's where it kind of originated from. But your MPI is basically linked to you as a healthcare provider. After you begin practicing and you develop a collaborative agreement, or whoever you're practicing with, or a physician that you're practicing with, that's when you apply for your DEA. Because you have to have a collaborative agreement for a DEA essentially. Because in the state of Michigan, we cannot autonomously prescribe controlled substances without a collaborative agreement. So your DEA is going to be, you have your own number, but it will be directly tied with a collaborating physician as well. In the state of Michigan, I was going to go through this in another video. We do technically have autonomous prescribing in terms of legend drugs. When I say legend drugs, that means regular drugs like antibiotics, statins, blood pressure pills, all those medications that we typically use on a daily basis. It is not inclusive to controlled substances. So that's kind of the loophole here and why you need a collaborative agreement with a physician, because you need that for controlled substances essentially. And you kind of run into issues with billing, but I'll talk to you about that after in another video. So when you're going to, look for a position, there's a few things that you really want to keep in mind. When you go to interview, this is why it's so important to understand or be able to articulate the role of an NP, because you have to really portray those strengths to that provider or that group or the practice, and what strengths you bring forth for the practice or patients essentially. So it's really important to be able to articulate the NP role in primary care and basically articulating your worth. What separates you from another candidate? What's the difference between an NP and PA? I always tell people to think about that too. We have that nursing background. You have, a whole slew of experience behind you, that really sets you above a lot of other candidates. So make sure that you think about that before you go in for an interview. So really understand the role of an NP. Really want to talk about health promotion and things like that, and education with patients, and family-centered care and so forth. The other thing too is you really want to look at the practice. Do your priorities match that practice that you're interviewing with? Because you really do. Obviously, you want to find a position too that makes you happy as an individual or as a clinician. So you really want to think about that practice as well. So looking at your own individual strengths or areas of improvement for yourself and things that you want to do to improve your clinical practice is another area to think about. Big thing is always ask questions about the practice. You're interviewing them as well. So you really want to find out, different details about who practices there. What's the typical practice patterns? How many patients do they see? Even like the population or the, trends in patients that you tend to see. And I have some more on the next slide as well. But you want to interview them too, because you definitely, number one, it portrays that you're interested in the position and, and that you're knowledgeable about their clinical practice area. So once again, you're interviewing them too. Afterward, obviously, it's always good to follow up with a thank you letter and personally write them a note or a phone call, essentially, after interviewing. In terms of contracts, this is a big thing too, and this is new for everybody. And it was new for me when I, went through all this at the very beginning. I did put up a good article through JMP in terms of different areas to think about in terms of contract negotiations. You really got to think about what you want as a clinician. Do you want full-time, part-time? Do you want, longer shifts versus shorter shifts? And that might not be available. It might just be what they need in the office. If you're full-time, contracts tend to be a little bit more stringent than a part-time clinician. There's different things that I'll talk to you guys about. You really want to look at things. Are you only going to be in the office? Do you have to do call? That's another thing you want to inquire about. If you're doing call, are you getting paid? Obviously, you want to get paid for call. How often are you going to be on call? How much are you going to get paid for being on call? Do you have to do hospital rounds? I would say that a majority of practices in primary care, tend to not have NPs do call or go to the hospital. In specialty practices, that's a little bit different, and they may expect you to do that. But you really need to inquire about that, what the expectation is in terms of being on call, as well as doing hospital rounds. And it gets a little sticky with the hospital rounds too because you have to get accredited, through the hospital as well. So, but it's something you want to ask about. And a lot of times nowadays, actually, private practices, not all of them are actually going to the hospital anymore, and they actually have hospitalists cover it. So you do want to inquire about that and how the practice actually manages that as well. In terms of compensation, this varies. This is a little bit old, so actually I posted a um, compensation report, and it's available on our Moodle page, and you can click on it. It varies depending upon number one, the area that you're practicing in, whether it's a specialty practice, um, or let's say if it's a nursing home versus a primary care versus a pediatric office. There's going to be variance there across salaries. I would say on average right now in Michigan, a beginning salary I wouldn't take less than, I would be expecting, I guess I should say, at least 50 an hour, which is typically equivalent to like 100 grand a year. Look at that report because it will give you an idea. Like, for instance, I practiced in ortho for a long time, and then I've also practiced in internal med. Internal med pays a little bit better than general primary care or family practice does. Orthopedics pays a little bit more. It just depends on the area that you're working in. So you really got to look at it in perspective of the area that moving into in terms of practice. If you're practicing in the hospital, with once again, we kind of talked about this, but the consensus model with nursing and advanced practice, you should be practicing in the area that you were trained. But there are people that practice in the hospital. There's a lot of people that practice in ERs and, urgent cares and things like that as well. Hospitals, or if you're practicing for a hospital system, they're going to have a bracket. It's just like nursing, where you have that bracket of, 1 to 2 year experience, 3 to 5, so on. So really, there's not much negotiation there in terms of NP practice in the hospital setting. Typically, there's not much there. There might be a little bit of variance, or you might be able to work with it a little bit, but it's pretty much set. Like they're going to have, just like nursing, where you come in and there's going to be a range, a pay range essentially for that. So it is different in the hospital in terms of that versus the outpatient setting. And in the outpatient setting, there's a couple other variables that you want to think about as well. And I think I have it on the next slide in terms of revenue and billing. Because there's some practices, like when I first started in general med, um, I actually received a percentage of what I brought in terms of revenue, in terms of billing. Some practices don't do that. I mean, it just depends, but it's an option, that you can look at. And usually that first year or two, you're not going to be that successful at it because you're not going to see a ton of patients. You really want to, that's another thing. You want to basically set kind of some guidelines before you move into practice. And that first 6 months, you really want to make sure that they are not overwhelming you with a huge influx of patients. And I believe that most physicians understand this, or most practices get this. But really, at the beginning, you should not be seeing a full load of patients, essentially. You really need to kind of gain experience before you kind of move into that type of practice. Everybody's different. Everybody's comfortable with something different. So it's what you're comfortable with. It's not that you can't. But really, the expectation that first 6 months is really more of like an orientation, and you're going to be learning every single day, and that'll be like that forever. But that first year is a transition, and you definitely, you need more time to look things up and research things and look up labs and, just get used to the practice and who they refer to. So really at the beginning, it's a long orientation process. It's really important to meet with the biller. Some people do it in the practice. Some, bill outside of the practice. It just depends on the system that they use there. So you want to inquire about that too with the practice as well. In terms of contracts, this is really important because this is obviously a contract that you can be held liable for, for a period of time. And they usually, that first contract you do, don't do it too long because you want to be able to, you know, look at it again in the future with whoever you're practicing with and maybe kind of tweak things essentially. But once again, the basic things, you really need to inquire. Do I get vacation time or sick time? How much should I receive? And most physicians are really good about this. Or sometimes even they'll let you work with your schedule and, take unpaid leave if you need it, things like that. But you want to inquire about that, how much vacation or sick time you're going to get. A big one too is inquiring about what you get for CEUs or for continuing ed. You want to make sure that they're giving an allowance for it as well as time off if you do want to attend a conference. I would say on average, most give around 1,500 to 2,000 a year. So that is something that you want to make sure you include in a contract. Car allowance is probably not a very common thing that's there. However, this would be more pertinent if you were, let's say, practicing. There's some people that practice for nursing homes, and they may practice for three different nursing homes, and they may want mileage. So that's something I would think about. If you're practicing at one place, I wouldn't even bring that up. But if it is a factor there, then obviously bring it up as well. A phone or a pager, if you feel like that is more pertinent too if you're on call. If you have to take call or you have to go over do rounds, I would definitely inquire about that. Computers, I would say most practices provide this. Typically, it's the practice that has that. So usually that's not an issue. Malpractice insurance is another big one. Who's going to pay for your malpractice insurance? Mine is currently, I want to say it's 16 or 1700 a year. And it varies where you practice too, because they're going to ask you when you sign up for a malpractice insurance, like where you practice, how many hours you work, what's the population you see. Do you see children? Do you not see children? Is it only adult? How much experience do you have? A lot of that's factored in there. So you really want to get a ballpark of what you're going to pay for insurance, and your employer should be paying for it. In my experience, when I first practiced in internal med, my collaborating physician or the physician I worked with actually had my malpractice through the hospital system because we were actually affiliated with the hospital at that point in time. Now it's a little bit different, and I have my own independent coverage essentially, but there's multiple different companies out there, and I would really look at what they offer in terms of, an aggregate in a one-time incident. The one thing you want to make sure is that it covers previous incidents. There's certain malpractice insurances out there that you can get, and they may be cheaper, but it's not going to cover an event that happened in the past. And you need to have that. You need to have coverage from patients you've seen previously. There's sometimes they will only cover things that kind of pop up within like a year period. You got to make sure you're looking at timing. So that's super, super critical when you're looking at malpractice insurance. I have mine through NSO, and I'm sure you probably heard of NSO. Like, they've been around for years, and I know a lot of nursing students, even undergrad. Like, I even had it as a regular nurse, and I have it now as an NP, but that's who I have it through, is NSO. They are a little expensive, but I do feel like you get really good coverage. I have, and I honestly, I believe in getting 1 million and 6 million aggregate. There's different, once again, you can get less, but I kind of go with the max, and I get the 1 million and 6, per incident and per, in an aggregate. That's your own personal choice, but look at that too. It's something that I wouldn't skip on, essentially. And once again, you should really have your practice covering that anyways. But they are hesitant. They're going to say, why don't you get it through this or get less? And I disagree. That's covering you need your own malpractice, and you want a good one. Does the practice have their own malpractice? Because a lot of times too, if you're working with a practice, they should have their own malpractice as well. And in terms of your own, you definitely want your own. I would get your own. That's my personal take on it. And other things too. Insurance is another thing you want to ask them about. Do you get short-term, long-term disability? Factors like that too. If you're part-time, I say sometimes they're a little hesitant to give you coverage. It just depends on the practice. But usually if you're full-time, you definitely will have, insurance and short-term disability, long-term, etc. In terms of the term for contracts, you do want to review it. Like I said, that first one, I wouldn't make it too long, because sometimes they'll tell you 4 years, and I honestly wouldn't do that. Your first one, you want to make sure you do it in a shorter period of time, a 1 to 2 year contract. That's what mine was. I think it was a year or two. Some big things, like I mentioned, salary negotiation, you do want to include that or talk to them about that. Like, do you have the ability to change your salary at that 1 year mark if you do sign a 2 year contract with the practice? Because you don't want to be stuck at that, that profit or that salary, essentially, if you have the ability to change it. And the profit sharing basically is what I mentioned. Sometimes they'll say, This is your base salary or your base hourly rate. I was typically paid hourly, which I think honestly is kind of good. It goes both ways, but you know how it is. Sometimes you're in the office longer than you expect to be. Um, so you kind of gotta look at both. But my positions tend to have been an hourly rate. That's typically how mine has been. Um, I did have at the very beginning an internal med when I practiced. I did like a profit sharing, so it would be like you get 2% or whatever percent of what you bring into the practice for that year. And like I said, at the beginning, it's not the greatest because you're probably not going to bring in, a ton in at that first year just because you're not going to be seeing, a full maximum amount of patients. I mean, you may be, but it's something you can inquire about. Like if you want to add that on there, I would talk to them about it and look at a certain percentage with them. A competition clause is actually a big thing you want to think about as well. Some practices will want you to put a no compete clause in there, meaning that if you were to transfer or quit your position, you can't practice within, let's say, a 10-mile radius of your practice location or that current practice location. Sometimes it may be a 20-mile radius. If they do have this in there, make sure that the stipulation is nothing crazy like a 60-mile radius. I mean, that's unfeasible. If you were to leave, you don't want it to be like that. I mean, I would not go over a 10 to 20-mile radius there, but they literally will put that in there, a no compete clause. And it's because they don't want you to leave and take their patients, along with it. So sometimes they do that, add that in there. But you can talk to them about this and, make sure that the criteria there is nothing too strict, that you can't practice somewhere within, a certain area. So it's something to think about, whether you want that in there or not. I mean, I wouldn't put it in there unless they basically are bringing it up or making you put it in there. But just make sure that it's not too strict, essentially, if it is. Collaborative, in terms of duties, you want to look at what a typical week looks like in the office. How many patients do they see on average per day? How many they typically schedule for physicals, things like that. You want to look at stuff like that, like sick visits, physicals. What's your role going to be in that office? Are you going to have your own patients? Are you going to do a lot of preventative care visits? Sometimes they have an idea in the back of their mind of what path they want their clinicians to kind of take in the office. Inquiring about what other practitioners are there, obviously. How many physicians are in the office? Are there any other providers, like such as PAs or other nurse practitioners in the office? A big thing, too, is you want to look at the supportive uh, providers that you have with you. Are you going to have your own MA? That's a big thing because it really slows you down if you don't have an MA with you. And most don't have their individual MA. They'll have an MA for two providers or, a certain amount of providers, in the office. But you want to inquire about how many MAs they have working on a single day, essentially. Because that really makes a huge difference if you don't have help, or it slows you down if you don't have someone working with you. In terms of a secretary, usually they have obviously front office staff, or we, usually will have a manager, a clinical manager that works in the office that helps with big things you've got to think about, like who's doing prior authorizations, because obviously I'm sure you know by now that stuff takes an extraordinary amount of time. And as a clinician, it's very difficult for you to manage seeing patients and doing clinical care while also trying to deal with paperwork and all that. So you really want to inquire about that. Like where I've practiced, our MAs, our office staff, our managers pretty much did a lot of the paperwork, and we did. They would basically have everything organized for us, and then as a provider, you're just dealing with the last minute sign off and making sure that um, the prior auth goes through essentially and that it's correct. But really, you want to make sure that you have someone there to help you with that legwork with that because you could spend a ton of time doing that. I'm sure you already know by now. How many patients are you expected to see? So once again, at the very beginning, like I mentioned, don't try to cram in a ton of patients, and you want to lay that out there. For instance, at the beginning when I was a new NP, I would say they scheduled me every half hour, and they gave me 40 minutes for a physical, so that was really good, or 45, which is a lot of time. So and that's what was needed at the beginning. Like you need that time in order to see your patients and feel comfortable with it. So that's not an inappropriate thing to ask. And how many patients will I see at the beginning, how many well versus sick. Um, basically trying to kind of ballpark where you're going to stand in terms of how many patients you see with that. And it's not, like I said, it's you want to make sure that you're not overloaded at the beginning. So make sure that it's something reasonable. After certification, so big things, and this is another thing too. So when you're looking at who you want to become certified through, you want to look through what they require in terms of renewing certification. They're very similar. So ANCC and AAMP, it's every 5 years. Um, and AA, no, ANCC, who I've had, that's what I've been certified through. They have different criteria. Like you can meet, one would be like precepting, or one would be continuing ed. And there's certain brackets, like you have to meet, you have to get a certain amount out of each section, or one or two sections essentially out of there. And you actually get credit for practicing. So there's like little areas that you can kind of choose from in terms of meeting certification renewal requirements. And then actually online, you can actually keep track of it if you do ANCC. Like they have a folder that you can kind of keep up to date and add everything in there as you move through over that 5 year period. Or you update it like towards the end. That's how it was before they had it online. Or if you go back for your DMP, that's another thing. If you go back for your DMP, it fulfills a lot of your requirements for your certification for that period of time. So the big things that I always say, number one, look at the testing in terms of ANCC versus AANP. And number two, look at what's needed for recertification or renewal. They're both 5 years, but the requirements are a tiny bit different in terms of what's needed for each one. So I would literally, those documents that I posted up there, I would browse them and I would go through. There's a handbook on there for ANCC, and I know there's one for AANP. I would literally go through them and look and compare the difference between testing and then the difference between renewal. And that'll kind of help you understand which one you want to go through. They're both equally good. They're both great certifying bodies. So honestly, it's more of a personal choice in terms of which one you want to do. If you do ANCC, like for instance, it would be FNP / BC. That's what you would sign your name as. Or I'm sorry, your certification is. If it's AAMP, it's FNP / C. So it's just some way that you're signing your name based on which one you have. You can do both. However, I don't know if you would want to do that because you have to pay for both of them. The big thing, talk with others, see what other people are doing, see what your preceptors have done. Inquire about how their experience with AAMP or other students that you've met before previously, in a previous cohort. And I do know that a lot of students did take AANP, from previous cohorts. So, and they've had really good pass rates. So, but they're both equally well. So this will be conclude the lecture for this section, but I'm going to go through and add a couple other videos for, a little bit more details on ANCC and AAMP, as well as the document that kind of runs through the process of what you need to do in terms of certification, licensure, and MPI and all that. But obviously, feel free to please let me know if you have questions, and I will talk to you all soon. I hope everybody's doing okay. Thanks. Bye-bye.